Hello students, let us come to one of the most commonly asked topics from the nose, that is the tumors of nose and paranasal sinuses. Okay, the first question over here is, which is the most common benign tumor of paranasal sinuses? So most common benign tumor of paranasal sinuses, the answer to this is osteoma. Okay, so osteoma is the most common benign tumor of the paranasal sinuses. Now somebody asks you, what is the most common site? Most common site for this osteoma, answer is frontal sinus. Okay, so frontal sinus, then followed by frontal we have the ethmoid sinus, right? Okay, now you see over here in this photograph, this first is the X-ray. So this patient presented with headache and X-ray was done over here in the paranasal sinuses. You can see that there is a osteoma, right? So you can see over here we have an osteoma over here. So now a CT scan was done and you can see this osteoma. This osteoma you can see over here, it is actually blocking the frontal ostium. So frontal ostium has become very, very narrow. And because of that, there is collection of secretions, and because of that, patient has headache. Okay, remember the typical headache for frontal sinus is office headache. So you see very small opening is left, so patient presented to us with office headache, right? Okay, treatment means excision of osteoma. So you have to remove the osteoma. Now earlier the treatment was to do a surgery from the outside. Okay, so remember I told you about the frontal sinus trephination surgery. So you make an opening in the frontal sinus, you open the frontal sinus by giving a incision around the eyebrow, and then you cut the bone, you remove the bone and you remove the tumor. But nowadays what we prefer is the endoscopic sinus surgery. So we like to go inside, from inside the nose under the vision of endoscope, and we try to remove this whole osteoma, right? Okay, so osteoma treatment is surgery. Yes, depending upon the site of osteoma, you can decide what type of surgery you want to do. The preference is always for endoscopic surgery, of course, because nobody wants a scar on the face. All right, now the next question, most common benign tumor of nasal cavity. So the most common benign tumor of the nasal cavity is inverted papilloma. Inverted papilloma is also known as Ringer's tumor. Okay, now this tumor, inverted papilloma, is generally seen in males around 50 to 60 years age group. Okay, and this tumor, the inverted papilloma, how will it present? You see, this tumor will generally present with unilateral nasal obstruction, right? Unilateral nasal obstruction, there may be some history of bleeding, that is epistaxis, okay, but that is generally mild. It may or may not be present. This history may or may not be present. So generally the patient's complaint is unilateral nasal obstruction. Okay, right? Now let's see over here. This inverted papilloma, as you can see in the photograph, when you examine this papilloma, it looks like a polypoidal mass. So as you can see over here, it looks like a polypoidal mass. Now, something important about this inverted papilloma arises from a special membrane that is known as Schneiderian membrane. Okay, so it arises from a special membrane known as Schneiderian membrane. Now, this Schneiderian membrane is a special membrane in the nasal cavity. It consists of transitional cell epithelium. Okay, so it consists of transitional cell epithelium, and it is found in the lateral wall of the nose. Okay, it is found in the lateral wall. The Schneiderian membrane is seen in the lateral wall of the nose. okay, in the middle meatus area. You may also find it inside the maxillary sinus, right? So we have this membrane on the lateral wall of the nose in the middle meatus area, or you may find it in the maxillary sinus. So now where will the inverted papilloma rise? It rises from this Schneiderian membrane. So that's a special membrane consisting of transitional cell epithelium, right? Okay, so when you examine this patient, you will see that the patient has a polypoidal mass, and you can, if you try to pass your probe, you will see that this polypoidal mass is attached to the lateral wall. Okay, so it is attached to the lateral wall of the nose. It is free from the septum, right? Sometimes if you touch it vigorously, it may even cause some bleeding. Okay, now this inverted papilloma, how will you make a diagnosis that it is inverted papilloma and not just some simple polyp? You see, what will you do? You will take a biopsy. Now when you take a biopsy, what will you find? So you do a biopsy, and when you send this biopsy for histopathological examination, you will see that this polypoidal mass, it has papillomas. So the histopathology shows you that it has papillomas, but these papillomas, instead of coming out, these papilloma, they grow within its own stroma. Okay, so that is why these papillomas are known as infolding or inverted papillomas. You see, these are known as infolding or inverted papilloma, and that is why this tumor also got the name as inverted papilloma, because the papillomas of this disease, they grow into its own stroma, right? Okay, so you have made a diagnosis of inverted papilloma. Now what will you do? You'll plan for surgery. Now for planning of surgery, you need to know what is the extent of this papilloma, right? And to find out the extent of the papilloma, you will need to do a CT scan. Okay, now this CT scan is a contrast enhanced CT scan. Okay, why? Because it's a tumor. So in the tumor, you also want to see the blood supply. You want to see whether it is enhancing or not. So you do a contrast enhanced CT scan. So this is the contrast enhanced CT scan of a patient with inverted papilloma. Now what do we see in this? Again, remember, the inverted papilloma is a unilateral disease. Okay, remember, sometimes you may confuse this with an AFRS. Remember the AFRS we discussed previously. So with the AFRS CT scan, you can get confused. Remember, number one, in AFRS we did a non-contrast CT scan. Now here we do a contrast enhanced CT scan. Okay, now both of them, it's a unilateral disease, but let's look carefully over here. In a inverted papilloma CT scan, you will see that this is the mass in the nasal cavity. And if you compare with this mass over here, you will see that there is a difference in the density. Okay, with the maxillary sinus, if you compare, there is a difference in the density. The mass in the nasal cavity is more brighter. Why? Because it has taken the contrast. Okay, so this is hyper intense. Okay, right? Or hyperdense. You can say hyperdense. It is not isodense. Okay, it is not equal in density to the maxillary sinus. Why? You see, this is the mass in the nasal cavity, and this is the collected secretion. Because the secretions of maxillary sinus are not able to go out, so they have collected inside the maxillary sinus, right? So we can clearly see that there is a difference. Number two, in case of AFRS, you see densities. Remember, we called as double dense appearance. Now in AFRS, you know that the mass is heterogeneous in appearance. There is densities, that is because of deposition of heavy metals in the dense fungal hyphae. But you look the mass over here, you see this mass is isodense. Now when you look in this mass over here, in case of inverted papilloma, you will see that this mass may be hyperdense because of contrast, but if you see, it is homogeneous in appearance. There is no separate density. It is homogeneous. Okay, right? Now remember, in AFRS you will see these densities, and the densities are seen in the nasal cavity as well as inside the maxillary sinus also. So densities are everywhere. Okay, but over here this is hyperdense, so we know that this is enhanced. Okay, this has taken the contrast, and this is isodense. Okay, the maxillary sinus part is isodense to the other body tissues because this is just a collection of secretions. Okay, and there are no densities. This is a homogeneous mass. So this is how we differentiate inverted papilloma and AFRS. Okay, so remember, AFRS patients, these patients do not have any history of allergy. There may be bony erosion present, again because of mass effect, but it's a benign tumor, so there will be no invasion once again in inverted papilloma, right? Okay, so what is the treatment for inverted papilloma? The treatment nowadays for inverted papilloma is transnasal, that means throughout the nose, endoscopic excision. Okay, so we do a endoscopic excision of this inverted papilloma, that is transnasal, through the nose, through the nasal cavity. Okay, endoscopic excision of the inverted papilloma. Earlier there were different open surgeries done, but nowadays with the help of endoscope and the endoscopic view we can remove the whole papilloma. Okay, remember, the inverted papilloma is notorious. This is notorious for recurrence. Alright, the recurrence was earlier very common. It was very common earlier. Why? Because we could not see inside the nasal cavity. We did not have the CT scan. We did not know in which cavities it has grown in. So recurrence was very common earlier. And the old book says that the recurrence will depend upon the type of surgery done. So if you do a just the surgery in the nasal cavity, of course the recurrence rate will be very, very high, almost up to 60%. And if you do a surgery where you do a total maxillectomy, okay, so these are all open surgeries which I am talking about, the recurrence rate may be as low as 2 to 3%. Okay, so you see, it was depending upon the type of surgery. Why? Because earlier there was no CT scan, and when you are doing the surgery you don't know which cavities it is hidden, right? So that problem has now been solved by the CT scan and the endoscopic excision, where we can go inside all the cavities and remove this papilloma in total, right? Okay, remember, this papilloma may also undergo change into squamous cell carcinoma. Okay, 10% cases, the inverted papilloma may change into squamous cell carcinoma. Now, if there is a squamous cell carcinoma and if you remove the papilloma, there are higher chances of its recurrence. Alright, so more the recurrence, if the papilloma is recurring again, so more the recurrence, patient has more chances of having squamous cell carcinoma in it, right? So that means it requires more radical treatment. Okay, let's come to the AFRS CT scan. I'm just trying to show you over here, this we have discussed in the fungal. So you see over here, it is again a unilateral disease, but you can see the densities, it is a heterogeneous mass both in the nasal cavity and the maxillary sinus, right? Okay, now after discussing the benign tumors, let us talk about the malignancy. So malignancy of nose and paranasal sinuses. Alright, nose and paranasal sinuses. First question, which is the most common malignancy? Answer is squamous cell carcinoma. What is the most common location? The most common location is maxillary sinus. That's the most common location. Okay, remember, we also have squamous cell carcinoma on the nasal septum, anterior nasal septum, and that's because of repeated irritation. Okay, we call it as nose picker's tumor. So if there is a squamous cell carcinoma on the nasal septum, anterior nasal septum, it is known as nose pickers tumors because it is generally due to repeated nose picking, right? Now, similarly, the malignancy of nose and paranasal sinuses is also dependent upon occupation. Okay, how? Suppose a person is working in wood industry. So when I say wood industry, that means furniture work and all. Okay, we have more common adenocarcinoma. And if the person is working in nickel industry, then we have more common squamous cell carcinoma, right? So occupation also has a role in development of malignancy of nose and paranasal sinuses. Now, before we discuss the presentation, okay, let us discuss a staging method and we'll understand the presentation along with the staging itself. So let's discuss the staging for maxillary sinus carcinoma. Okay, so maxillary sinus carcinoma, I am directly taking you to the staging, and for this staging we will first discuss the on-grains line. Now this question on-grains line is important. It has been asked multiple times in the different exams. So what is this on-grains line? This is an old method of staging for maxillary carcinoma. What we do in this, you draw a line from this point, that is the medial canthus, to the angle of mandible. Okay, so you draw this line. Now you see, when you draw this line, it divides the maxillary sinus into two parts, upper part and lower part. Upper part we will call as suprastructure, lower part we call as infrastructure, right? Now you see, the suprastructure is near the orbit. So we'll have a lot of cranial nerves and all these important structures, eyeball, in the suprastructure. Okay, so they are in the vicinity of suprastructures. That means if there is any malignancy in the suprastructure, what will happen? The prognosis for that is poor because it can involve those all important vital structures. Whereas if a malignancy is there in the infrastructure, now this malignancy will involve the palate and you can all surgically cut and remove the palate and the malignancy. So the prognosis for infrastructure malignancy is good. Okay, so this is one of the earliest classifications used for maxillary sinus carcinoma. Okay, then we have another classification which is known as Lederman's classification. The Lederman's classification uses two lines. These lines are known as lines of Sibelius. Okay, the first line passes through the roof of the maxillary sinus. The second line passes through the floor of maxillary sinus. So there are these two lines of Sibelius, and because of these two lines, now what happens? These structures are divided into three parts, that is the suprastructure, mesostructure and infrastructure. So once again, what do we see? Suprastructure as orbit, eyeball, important cranial nerves. So prognosis over here is going to be poor, whereas infrastructure prognosis is going to be the best among the three, right? Once again, okay, remember this thing, the suprastructure of Lederman, you see over here, it is quite different from suprastructure of on-grain, right? Okay, don't confuse between the two nomenclatures. These suprastructure and infrastructure are different from those. Yes, in both of them, suprastructure has a poor prognosis and infrastructure has a better prognosis, right? Okay, nowadays, what classification do we use? We all use the TNM classification. Okay, so what is this TNM classification? Let's discuss the T classification, the T staging for maxillary sinus carcinoma. So what is T1? T1, the malignancy is limited to the maxillary sinus mucosa. So since the maxillary sinus mucosa is involved, you see, this patient generally in T1 stage will have no presentation. Okay, you will not see any presentation. This patient will be usually asymptomatic and we generally do not get to discover the T1 stage, right? Now from this T1, from this maxillary sinus mucosa, this malignancy goes and involves the bone. So you see what all bones it is involving? It can involve the inferior bone, the medial bone, the lateral bone. right? It can involve all these three bones except the posterior superior wall. Except which wall? Posterior superior wall. Why? I'll tell you later in the next. Okay, so you do not, this does not involve the posterior lateral wall, but it can involve the other walls. So let's say it involves the medial wall. Okay, so if it involves the medial wall, it can come into the nasal cavity. So T2 malignancy involves the walls except, so bony wall is involved except the posterior superior wall. So how will T2 present? So if there is a nasal mass, so patient may have some spotting, some bleeding, okay, a few drops of blood may come out. Because of bone involvement, there may be pain. You see, inferior wall is involved, so you see there may be some dental pain, all right, or the tooth may become a little loose, right, or may it involve the lateral bony wall. So this is T2 stage. Now T3 stage. T3 stage. So which wall it is involving? It will involve the posterior superior wall. What is at the posterior superior wall? You see, at the superior wall we have the orbit. You see, in orbit is involved, prognosis of course becomes bad. So it involves the superior wall. Remember, over here it can go into the ethmoid. Ethmoid again means that the wall of orbit is involved. So if ethmoid is involved, of course it will be considered as T3. Okay, so ethmoid involved, it will be considered as T3, of course, right? Now it may also go into the subcutaneous tissue. So if it is gone into the subcutaneous tissue, you will see that the skin of the face, it starts having some changes. Just like the PUD orange appearance, okay, the subcutaneous tissue is involved. So the skin over here will become attached to the underlying bone, right? Okay, so that is the T3 stage. Now in the T4A, what happens? This malignancy, it goes inside the orbit. Okay, so now it goes inside the orbit, right? So the eyeball is involved, right? It is inside the orbit. Or it may fungate and come out into the face. So it is involved and it comes out into the face, right? So you can see that there is an ulcer on the face. It's a malignant ulcer. The malignancy has burst and come out on the skin of the face, right? So that we will call as T4A. Now, if it involves the cranial nerves over here, or it goes into the intracranial cavity, then it is known as T4B. So T4B, it goes intracranial or it involves the cranial nerves, that is known as T4B stage, right? So that is the T staging for maxillary sinus carcinoma, right? Okay, now let us discuss the treatment. I'll remove all this. Let us discuss the treatment. Now the treatment for maxillary sinus carcinoma is mainly surgical. Okay, in the initial phases it is mainly surgical, but in the late stages it is surgery plus radiotherapy. Okay, let us see over here. Let's see over here. Now T1, as I said, T1, what will you do? T1, you see, it is limited to the mucosa. It is generally not discovered. If you by chance discover it, you remove it, surgery, it is more than enough. Okay, now T2, it has involved the bone, right? So it has involved the bone. What will you do? You will do surgery. Okay, which wall is not involved? The posterior superior wall is not involved. Okay, so what can you do? You can do a partial maxillectomy. You remove the part which is involved and this will solve your problem. Okay, so only surgery is enough, right? Now T3. Now in the T3 we know that it has involved the wall of the orbit, right? So it has involved the wall of the orbit. So now what will you do? You will do a surgery. Which surgery you will do? You will do total maxillectomy. Okay. So what do you do in total maxillectomy? You will remove the whole of maxilla, right? So as you can see over here, I am underlining all this. So what you will do? You will remove the whole of maxilla, right? Like this. Now you see, because the eyeball is not involved, I am trying to save the eyeball. In an attempt to save the eyeball, I don't want my patient to go blind without having any eye symptoms. Alright, I know by my imaging that it has not involved the eyeball, but I may leave some part over here. That is my worry. Okay, so now what I will do is, when I do the surgery, I will also give post-operative radiotherapy over here. Okay, so that if some remnant is left, that is killed by the radiotherapy. So T3 will be surgery plus radiotherapy. Now T4A. T4A, what will you do? T4A, you have to do extended maxillectomy. So what do you mean by extended maxillectomy? Suppose the skin is involved, then you have to remove the skin also. Okay, and you have to repair the skin of the face by doing some flap surgery. Suppose the eyeball is involved, then you have to do orbital exentration. So if it is gone into the eyeball, then you have to do orbital exentration. Okay, so T4A, you do the surgery, and along with that you also give radiotherapy. Okay, so this is the staging. T4B is generally only palliative therapy, especially if it has gone intracranial. Okay, you give palliative therapy. That is the treatment generally done for T4B stage. So this is how we treat the maxillary sinus carcinoma. Okay, so you see, only surgery is only in the initial phases, but mainly we give surgery plus radiotherapy as the treatment for maxillary sinus carcinoma. Okay, right. Now let's look at a question asked recently in the exam: most common malignancy of the maxillary antrum. It was a very simple question. Answer is squamous cell carcinoma, asked in the FMG June 2018 exam. Okay, let's go over here to look at some other rare malignancies of the paranasal sinuses. We have over here esthesioneuroblastoma. Okay, so what is esthesioneuroblastoma? If I tell you the other name, it will be very easy. The other name is olfactory neuroblastoma. So this malignancy of the nose, olfactory or esthesioneuroblastoma, it arises from the olfactory neuroepithelium. Okay, it arises from the olfactory neuroepithelium. Now, where is this olfactory neuroepithelium located? We all know it is located in the olfactory fossa. That means the roof of the nasal cavity. So therefore, this esthesioneuroblastoma, it arises at the roof of the nasal cavity, cribriform plate of ethmoid, and from there it grows downward. Right? So easy, it arises in the roof and it grows downward. Some part may also grow upward into the anterior canal fossa. Just remember that also. Okay. Now, how will the patient present? Once again, patient presents with unilateral nasal obstruction. Okay. On examination, what will you see? You will see a mass which is coming from the anterior cranial fossa. Okay. It is coming from the roof of the nasal cavity. So what will you do? Will you take a biopsy? No. You will not take a biopsy immediately. Some mass is coming from the roof. It can even be brain. It may contain dura and the other meninges as well as the brain tissue. So first thing you will do an imaging, right? So you can do a MRI. So over here we have done a MRI. You can see over here that this is a tumor. Alright. So this MRI clearly shows you that this is the boundary. It's a tumor. It is different from the brain. Alright. Now you can go and take a biopsy. Once you have established that this is not the brain tissue, now you can go and take a biopsy. So a biopsy is done. What do you see in the biopsy? So you will see that this is a tumor in which, you will have these biopsy reports, small round cell tumor, something like that. but very important. This question has been asked in the exam, so very important. The examiner will mention you either neurofibrillary stroma is present or there are neurosecretory granules. The moment the word neuro is mentioned over here, you should think about olfactory neuroblastoma, okay, or esthesioneuroblastoma, right? So neurofibrillary stroma or neurosecretory granules, so that indicates it's a esthesioneuroblastoma. The treatment for this is once again endonasal endoscopic sinus surgery. Okay, so we have endoscopic, endonasal, that means through the nose, endoscopic, that is with the help of endoscope. We have the excision. Okay, so excision of esthesioneuroblastoma. This is the current treatment of choice for this tumor. Okay, right. Let us go to another rare malignancy which is known as midline lethal granuloma or Stewart's granuloma. Now, what is this midline lethal granuloma or Stewart's granuloma? Now, this is a rapidly progressing midline lesion. Okay, so you see, this is a rapidly progressing midline destructive lesion. So you see, this quickly destroys the face and nose. Okay, face and nose. That is why it is known as midline lethal granuloma. Now, this tumor, also known as Stewart's granuloma, it is generally a T cell lymphoma or a NK cell lymphoma. So, patient present to you with complaint of a lesion or an ulcer which is rapidly progressing and it is destroying his nose and face, as you can see in this photograph over here. So, what will you do for this patient? You will take a biopsy, okay, and you will send the biopsy for histopathological examination as well as immunohistochemistry examination, and that will help you identify the type of tumor. Generally, it is a T cell or a NK cell lymphoma. That is important. That is generally asked in the exam. Okay, the treatment is chemotherapy, and that depends upon the type of lymphoma we have at our hands, right? And this patient needs to be treated quickly. You see, the name is lethal. So otherwise, if you don't act quickly, this tumor may kill the patient very quickly. It is lethal, right? So treatment has to be quick, and the treatment nowadays is possible with the help of chemotherapy. Okay.